Okay, great. Well, thank you so much to the whole BayesiaLab team for organizing this great conference and for having me here. I'm sorry for the flickering screen, but I also wanted to really thank this BayesiaLab team because this was my introduction to Bayesian networks. I was asked to read this article when I was a graduate student at Carnegie Mellon University getting my degrees in civil and environmental engineering and then another degree in a department called Engineering and Public Policy. And that's where I learned about these. And this article was called Bayesian Networks Without Tears. And I think many people in the class felt that even after we read this article, there were tears involved. And then along comes BayesiaLab. Many years later, I discovered it. Thank God for BayesiaLab. So anyway, thanks for all your great work. So I'm going to talk about something completely different from what's been discussed today. Whereas Steve talked about the animals, I'm going to be actually talking about humans. And specifically about the risk that use of antibiotics in livestock actually may pose to human health. I'm going to be using Bayesian networks to explore a data set collected from hog farm workers and their families living in North Carolina. And I'm going to talk about my different algorithms that I tried for building a predictive model. And here I'm going to give a caveat in advance. I'm not a computer scientist, and so I'm sure I can use advice from the experts here on perhaps a better workflow or different algorithms I might try. But nonetheless, I'll tell you what I found so far. And then what this network says about interventions that might be helpful to decrease the risk of these superbugs. The risk is superbugs spreading from animal farms out into the human population. And my colleague, I have to say, the microbiologist would be very dismayed to hear me refer to the term superbugs. So it was really on her behalf, Stefan, that I said, oh, you can't call it superbugs in anything that goes out public. So a little bit of background on this. Probably most of you know that in modern livestock production facilities, it's typical to treat the animals with antibiotics, even if they're not sick. Now, a couple years ago, the U.S. Food and Drug Administration made it basically illegal in the U.S. to treat animals with antibiotics just to make them grow larger. That was the sort of common belief in the industry, was you should continuously dose your animals with antibiotics because it'll make them grow bigger. So what a lot of the industries are doing now anyway is they're still dosing their animals with antibiotics, and they're just saying, well, we really need it to prevent disease. It's not for growth promotion, it's for disease prevention. So in the US, more than 70% of antibiotics used actually are for livestock, not for humans. And you can see, this is again in the US, this kind of slow increase over time in the mass of antibiotics used every year for livestock production. Now, one problem with this, of course, is that there are zoonotic pathogens that can jump from one species to another. And it so happens that it was discovered for the first time in 2004 in the Netherlands that actually Staphylococcus can jump from hogs to humans. And this was discovered because a 6-month-old infant came to the hospital for a surgery. And there was routine screening done at this hospital to see if patients being admitted were actually carriers of Staphylococcus. And this child was a carrier of Staphylococcus that was resistant to a very important antibiotic, methicillin, which actually represents a broad class. So this child was colonized, and then the hospital, the doctors also tested the child's parents, and it turns out they were actually colonized. I've gotten ahead of myself here anyway. It was traced back to the family hog farm. So the issue is that staph can acquire antibiotic resistance when you continuously treat the animals with these antibiotics. The pathogens the animals carry can develop a resistance that those resistant pathogens can then jump from the hogs to the humans. And so I got a bit ahead of myself talking about this 6-month-old Dutch infant who was colonized with Methicillin-Resistant Staphylococcus, which is called MRSA. The parents had it. the doctors started treatment and really had difficulty getting rid of this MRSA in the parents and the child. And for those of you who don't know what MRSA is, it causes a nasty skin infection that in a mild form can look like that, but it actually can be fatal. It can become a blood infection. There's also, it can cause pneumonia. And so in the US, right now there are about 75,000 or so cases of MRSA a year, and about 10,000 of those are fatal. So while in most people it just, MRSA becomes a skin infection, it can be fatal if not treated. So it's a real problem when this organism develops a resistance to an important class of antibiotics. Now ever since this first case in 2004, there have been a growing number of studies to see, well, how often do these nasty pathogens actually jump from hogs to humans? And this is from a review that one of my students did. She looked for every single paper published in the world up through 2017 to see how many studies there were. She found all studies that looked at MRSA in humans and whether they had come from hogs or not. So what these are showing here is basically studies that have been done of these different human populations, people who work at hog farms, conventional ones that use a lot of antibiotics, alternative farms that don't use antibiotics except really if the animal is sick, slaughterhouse workers, families living with these hog farm workers, families working with living with workers who work at these organic farms that don't use all these antibiotics, community members, veterinarians that work with hogs, healthcare workers, and hospital patients. And what these are showing is that kind of pooled across different studies, these studies have shown about a quarter of the workers at hog farms actually are carriers of MRSA that originated in the hogs. So that's a lot compared to about 2% of any of us will be a carrier of MRSA. We're not necessarily symptomatic, but it's much higher in these hog farm workers, and you can see much higher in workers who are working at these big industrial operations that use a lot of antibiotics. An interesting finding, too, was that this is among hospital patients. MRSA is a big problem in hospitals. It can cause fatal infections, but this is showing a large portion of those infections in these particular studies actually were traced back to swine origin. So the MRSA had actually somehow originated in swine farms. So there's a little bit, I hope I've convinced you of the problem. Sorry, this is just a map from Europe, so I'm not just talking about the US. And this is from the World Health Organization Europe region showing the percentage of invasive staph infections in different European countries that actually are MRSA, the ones that are resistant to this antibiotic. So you can see, like, in Spain, it's 25 to 50%. Here in France, 10 to 25%, and so on. So anyway, common problem worldwide. And the question is, how much really is livestock use contributing? So my objective in this research was to figure out, well, what are the risk factors besides using antibiotics on these hog farms that are leading to this jump out into the human population of these superbugs? And can we build a model that will kind of predict these risks and offer some insights about the potential risk reduction that might be offered by interventions? And so for my methods, I have wonderful colleagues who collected a data set from 198 children living with hog farm workers in eastern North Carolina. And I'm a professor at the University of North Carolina. It turns out in North Carolina we have more hogs than humans. And this map shows the density of hog farm operations in the state. You can see there's a whole lot of them, right, in this eastern part of the state. Many, many hog operations. You might have heard in the recent hurricanes, the waste lagoons overflowed. My colleagues actually recruited these families to participate, went into the households, tested the worker and a child for carriage of MRSA through nasal swabs. Again, you can be a carrier and not be symptomatic. And then they administered lengthy questionnaires, and the questionnaires asked about occupational practices, household practices, behaviors, hygiene, all kinds of things that might influence the risk of MRSA coming from the hog farms and infecting these children. So this is just an upload of the questionnaire data into BayesiaLab, just a screenshot, but basically there were 98 potential explanatory variables and only 198 observations, right? So it's a very wide data set and unfortunately not very tall, so this posed a challenge, like can we really do anything with Bayesian networks with just 198 observations and 98 columns for each one? But the kinds of things that were included in these variables, whether their child or parent had been hospitalized recently, whether the child attends daycare, pet ownership was one that I'm not showing here. Oh yeah, hand washing behavior, workplace hygiene, kinds of activities the parent does at the hog farm, lots and lots of different variables. So my colleagues had initially analyzed this data set with log binomial regression. And this regression approach was kind of overwhelmed by the large number of variables, and they really were, they found 4 factors that seemed to be associated with the risk that the children would be carriers of this MRSA, but they concluded that all these other variables, all other 94 variables were null or non-interpretable due to insufficient numbers. So basically, they were really having a struggle kind of untangling this big data set. And so I tested multiple learning algorithms in BayesiaLab, and here's where I probably need help on the workflow. But I just kept, you know, it's so fun to play with. I kept trying different things. And I actually tried building 17 different models. Each one, I used sort of a different sequence to select the variables from the 98 that would be included. And these are the different algorithms that I used initially just to select variables. Use different combinations of these things, like, and then in each case, I would eliminate things that weren't connected to what I'm trying to predict, MRSA, and then I would eliminate things that didn't have significant mutual information in the end at a certain level of significance. So lots of different algorithms that I tried, and in the end, from all these 17, actually, and then I tested the accuracy just with cross-validation. For those of you who don't know what cross-validation is, basically you take your data set and you arbitrarily divide it into pieces. In my case, 5 different pieces, and I basically build the network with 4 out of the 5 pieces, and then I see how well it predicts the other piece. So that's kind of what this is supposed to represent. Each time you have a set of data to build the model, the training data, and then a set that you use to evaluate how well the model predicts. And you do this over and over again. And I did this a bunch of times, basically, a bunch of iterations of 5-fold cross-validation to see how well each of these sort of sequences of algorithms was working. And then the way that I evaluated, what I really wanted is a model that could really predict which children would be most at risk. Sort of what I'm envisioning is, you know, you could go in and administer questionnaires in a household and then sort of flag the ones where you might need to intervene. And so the way I evaluate how well the model works is with what's called a receiver operating characteristic curve. Who here has heard of a ROC curve? Lots of you, but not everybody. So so everybody's up to speed on it. This is a common way to evaluate the performance of a model that's intended to classify something as either a yes or no. In this case, somebody's a carrier of MRSA or not. And the idea is here, this is showing the false positive rate. So how many people who are not MRSA carriers are wrongly classified as MRSA carriers. And this is the true positive rate. So how many of the people who are really MRSA carriers is this model predicting? And this shows random guess. Like if you just flip a coin and you were to plot this, you know, you would end up with that dotted line. And what we're looking for, the perfect classifier would look like this. The line would go up here and over here. But you just never have a perfect classifier. So there's always some trade-off between being able to detect the cases without having too many false positives. And the indicator of that is just, it's the area under this curve. So the idea here is that you have this trade-off. For example, if this is for a model, you would say that if you want to detect, say, this is about 45% of cases, you're going to have to accept a 20% false positive rate. This is not a very good model here. If you want to detect closer to 80% of cases, your false positive rate is going to be 50%. So that's the idea. It's a common metric used to compare the performance of classifiers. So what did I find out? First of all, I'll say something about the data set, that in this data set of 198 children, 28 or 14% were carriers of MRSA. Now, my colleagues also took nasal swabs from a group of sort of matched children in the community who didn't live with hog workers, and the prevalence in those children was 6%, but nationally it's only 2%. So it may be that, you know, living in these communities, these MRSA are getting to the children living with the hog workers and then possibly spreading elsewhere. But that's just background. So I tried these 17 different algorithms, and multiple of them produced the same networks. So this was the result of one set of algorithms, a nice simple model. Here in the middle is what I'm trying to predict. Does the child have MRSA? And these are the different predictor variables that were left at the end after screening from all these different possibilities. There's another one where I took this network and I said, well, I'm going to force add the information about the variables that my colleagues had found to be associated with MRSA from their log binomial regression. So it's a little bit more complicated than that one. I just force it to add those nodes. Now, this is a terribly complicated model, obviously not realistic. And that's from a different sequence of algorithms that kind of leaves more things in. And this is the fourth one that came up, which is basically this, and then I add the prior evidence. So what do we do with this? Well, using Occam's razor, the principle that kind of less is more, I went with the simplest model. And actually, its performance is really just about as good as this much more complex ones, and it holds up much better over cross-validation. So let's see how well this does. And so this is actually, this model has pretty good accuracy. If I just develop a prediction from the model built from the whole data set, and I go back and predict each observation, this is what this ROT curve looks like, and the area under it is just over 0.9, which is good. But then we want to see if that holds up under cross-validation. So again, I did multiple iterations, 20 of them, 20 different sets of 5-fold cross-validation, and each time I randomized the data set in a different way. And this holds up pretty well, so this was like the median of them. And this is the worst and the best ROT curve areas under cross-validation, so it's about 0.85. So this is a pretty good model. I was actually really pleased. I thought, wow, this pretty small data set has some information in it. And then we can use it to gain some insights, actually, based on the variables that are left in the model, and look what happens when we vary these. So the thing that was most associated with MRSA risk in the children was actually whether the parent is bringing home any of their clothing from the hog farm. They're working at the hog farm, and then they're trucking home and wearing their coveralls and whatever else. And the ones, so we could use this model to see what really happens. So if you remember, the base prevalence of MRSA was 14%, but if the parent is bringing home their face mask and their coveralls, this raises up to 36%. On the other hand, if the parent leaves these things at the hog farm, then the risk of the child being a carrier decreases to less than 2%. So that's an important insight, because then you could say to the farms, you need to provide a clean room where workers can shower and leave their work gear. Very easy intervention. An interesting finding also was that one of the data items collected was the type of health insurance that the child has. Now in Europe, you're lucky enough that you have a universal health care. We don't have that here. So some of these children had no insurance. Some had insurance that was provided by the hog farms, and I'm not sure exactly what that looks like. Most others who had any form of insurance had Medicaid, which is like for low-income people in the US, and a few had private insurance. So this is like the Medicaid and private combined. But an interesting finding is that the children who had company insurance, which was more than were insured by the other types of insurance, actually seemed to have a higher prevalence of MRSA. And if I just compare that, so it was 43% almost in this group, whereas the children who had the public insurance had a prevalence of less than 8%. So this was an interesting finding, because it also suggests that maybe there's a need to go and visit the health clinics that are at these hog operations, which is where children are going for treatment. So there may be some transmission occurring through these health clinics, and nobody else had really discovered this before. Now, I love the web simulator, so I built a little web simulator for this, and I'm sorry it's flickering so much, but you know, this is a way that we could actually use this model to communicate with the hog farm owners and with the workers. And this is just a little screenshot of like how you could use the model, right? You could go and users can actually interact with it and say, well, let's say the parent brings the mask home. Let's say the child has company insurance, and you can watch what happens to the risk over here. So I like this because it's an easy way, again, that we could actually communicate these results and say, look how much this risk goes up because these workers don't have a place to leave their work clothing and shower at work, for example. All right, so limitations, obviously, very small sample size in this case. It was also a cross-sectional study, and ideally, and I'm not an epidemiologist, I'm an environmental engineer, but my epidemiology colleagues tell me that ideally you want to follow people over time. But nonetheless, I think the model did really well for a small sample size. And just to illustrate, you know, obviously when we build a model that's to classify something, we have to make a trade-off between false positive and false negative rates. So this is just one possible trade-off, but you can get a pretty good sensitivity, you know, well over 90% without too bad of a problem of false positives, about 13% false positives. So that's really not too bad. And then again, like I said, I think a real use where I want to take it from here is my colleagues and I work with an organization in Eastern North Carolina called Rural Empowerment for Community Health that is kind of a gathering point for people concerned about the risks posed by this industry. And so we want to take it to this group and show them what we found and get the message out about the importance of leaving workplace clothing at work, and then potentially also educate the industry about the need for better occupational hygiene practices and figure out what's going on at the health clinics. So with that, I'll say that again with this model, I think performs pretty well and made some useful findings about the importance of workers leaving their work gear at home and the potential problems with the company health clinics. The web-based platform definitely can be useful in communicating these risks. And I would like to acknowledge our funding sources, mostly the National Science Foundation, but also a funding organization called the Thrasher Research Fund, and then I have many collaborators. My colleague Jill Stewart, a microbiologist, was really the principal investigator on this. I'm just the number cruncher. A number of our students, Rural Empowerment for Community Health, my colleague Chris Heaney at Johns Hopkins, and then there were many households and field crew that went out and collected these data. So thank you, and I'd be happy to take any questions.